So once we've done this procedure, the venous manometry study, so we have a good 3D rotational understanding of what the veins look like. We also have a sense of physiologically what the pressures look like. It's important to mention that those studies are all done awake. We want to know what the patients are actually feeling, when they're awake, obviously mildly relaxed for the procedure, but we don't want to add unnecessarily, or rather create error by putting them under general anesthesia where it may be a falsely negative study because of the general anesthesia reducing their ICP. We want to know exactly what they're feeling. And in some patients, you may even see that during the venous pressure measurement, crossing a little bit of that functional area of venous connection may actually induce them to have increased pressures and feel a headache as you're crossing through that area. And so that in and of itself is almost diagnostic. So who's a good candidate for stenting? I look for someone who has a diagnosis of IIH, ideally made by a multidisciplinary team or with strong input individually from neurology and ophthalmology, or someone who has seen ENT, has disabling pulsatile tinnitus, and no other causes, and that helps for me to hone this down to being the true cause of their tinnitus. And they've ideally tried medical management, and they have failed to have sufficient symptomatic relief from their medical management, or they have side effects. We know that the medications that are used in order to treat IIH are not necessarily completely benign. They certainly have their side effects, and not all patients can tolerate them at the doses necessary to treat their IIH symptoms. I usually use a rule of thumb of 8 millimeters for a pressure gradient. It's been shown that at least that threshold of a pressure gradient will not guarantee, but ensure some level of procedural success. Below this, patients can certainly have benefit, but that benefit drops off quite a bit. So a patient with very severe symptoms, a smaller pressure gradient, they just have to be counseled appropriately that, it's not a slam dunk that they'll improve from it, but if they're really out of options, it's something to consider. And then I look for someone ideally who has focal stenosis, an area that I can really span ideally with a single stent if at all possible.